Hello. This is a talk on vasoactive agents that you are likely to encounter in the ICU. Unlike some of the presentations that just throw a chart at you and say, here's alpha, here's beta, go ahead and memorize them, I figured work with a different conceptual framework that is the family tree. So, who's who here? On the right side, we have the inotropes. Whoa, that's too big. Sorry about that. It's going to be super hard to read. And there are two main branches. One branch is the Inode Dilators. And you guessed it, the other one is the Inode Constrictors. And as the name applies, these are agents that have inotropic effects as well as vasoconstriction effects. And these are agents that dilate vessels as well as constrict them. So starting with this branch of the tree, who are these Inode Dilators? There's two that we use commonly. One is Dopamine. And what do you think the other one is? It is milrinone. And we have yet another kind of off branch here, which is related to these two, but not often used, and that's isoproterenol. So who are the constrictors? Those are agents that at low ends have inotropic effects, but as you increase in the dose, they tend to have some kind of spillover onto the alpha adrenergic pathways or receptors. And those are dopamine and epinephrine. And then just to be complete, one other agent that is classically thought of as an inotrope as well as a rate to control agent is digoxin. Not your classic titratable vasoactive in the ICU. And kind of tying this whole group of agents together as well as the constrictors is calcium, which is needed for any of these drugs to have its proper action. So what are the constrictors? Again, we have kind of a branch of constrictors that tends to sort of bend over toward the inotropes, just as some inotropes kind of bent over to the constricting pathway. And that's not necessarily a class of agents, but this is norepinephrine, which is primarily an alpha agonist, but also has some beta activity, which improves contractility of the heart and to a small degree heart rate. Your classic pure alpha agonists, and we'll call them what they are, is phenylephrine. And finally, there are a couple other new pure pressors that are not alpha agents. Vasopressin, and new on the market, angiotensin II, and it's got some fancy trade name which I actually forget, so I will not bother you with it here. So, generalizations about use here. Generally, if you've got a blood pressure that's either borderline acceptable or okay, Inode Dilators are actually pretty appropriate for use. They will actually lower your vascular resistance, they'll increase your cardiac output, and you'll probably break even with a similar blood pressure. If you have a MAP of 55 and you from a failing heart or a heart that's experiencing or kind of a nidus of cardiogenic shock, you do not want to use Inode Dilators. They will kill your blood pressure, and you'll actually have no cerebral perfusion, no other solid organ perfusion. So you will be in pretty dangerous straits with that. In those cases, you do want to control what your problem is, whether it's an MI, flail leaflet, whatever, but you absolutely have to have a blood pressure to keep the rest of the body alive and keep you from coding. And so you'll use inoconstrictors in that context. Sometimes in shock states, you need both. You have a failing heart as well as a failing vasculature, so you can get away with monotherapy of an inoconstrictor in some of those contexts as well. The pressors are kind of your classic agent for bringing up vascular tone in various shock states, whether it's neurogenic shock or some kind of inflammatory condition such as anaphylaxis, septic shock, or a post-surgical vasoplegia. And again, some of your agents, what you choose depends on whether you want to support the heart with a little bit of beta activity with norepinephrine, or whether the heart is doing perfectly well and you just need to support the vascular tone with a pure alpha agonist. And this will actually often lower your heart rate. So if you have a great heart and it's cranking away at a very fast rate, phenylephrine is often efficacious in that kind of context. If you've got someone who has sort of a borderline EF and now they kind of revved up, say with sepsis, and you think as you raise the vascular tone with an alpha agonist, you might need a little bit of help, or the heart might not respond to that kind of afterload, kind of an alpha beta mixed agonist is totally useful in that context and might be the agent that you want to use. Finally, a few notes on these agents and how to use them clinically. They're kind of presented earlier as if you need a constrictor, you just pick one from the list. But they all have their personalities, and I think it's good to know a little bit about what differentiates them. First off, vasopressin is a very interesting molecule in a couple different circulatory beds. One is the renal circulation, drawn here, where we have the afferent arterial and the efferent arterial. It turns out to be vasopressin and also angiotensin II constrict the efferent arterial, whereas alpha agonists constrict the afferent arterial. And you can imagine with a little bit more resistance here that your filtration pressure is going to be better, and you might just get a little bit more urine that way. And indeed, some of the studies looking at vasopressin found trends, although not outcomes, suggesting slightly better creatinine clearance, higher urine output. But again, not any of the really hard renal outcomes, but sometimes it's more convenient to have someone make urine than not. The other thing about vasopressin is essentially there are no receptors in the pulmonary circulation, and so it's very important if you have hypotension and RV failure, you absolutely have to feed the right ventricle by increasing the blood pressure. And if you do so with alpha agonists, you will also increase the RV afterload, whereas if you do it with vasopressin, you'll increase the perfusion pressure of the right ventricle without substantially increasing the pulmonary vascular resistance, and you can actually use that very effectively in that context. The other thing is intensivists aren't very comfortable in using vasopressin above 0.04 units per minute. There's, I think, one study that went to 0.06, but again, this isn't a universally titratable agent where you turn it on and you can dial it to whatever you want to get the effect you want. It's thought that higher concentrations than 0.04 will lead to splanchnic vasoconstriction and problems with gut perfusion, which can lead to problems downstream. Phenylephrine is kind of curious in the sense that it tends to sensitize baroreceptors to a greater degree than other alpha agonists. So when using phenylephrine, not only do you get an increase in vascular resistance, but you tend to see some decreases in heart rate. And this can be very convenient in patients that are horribly tachycardic. And also in situations like hypotensive AFib, sometimes this reflex slowing can give you a slower RR interval, which could be highly convenient in managing patients with atrial fibrillation. Epinephrine is also a strong stimulant of glycolysis, and so when using epinephrine in shock, you often see an increased lactate production, and you run the risk of kind of chasing your tail, where you have a situation where you believe there's a perfusion deficit, you turn on the epi to take care of it, and then your lactates start sailing up, and you start giving more fluids and more drugs than you really need. So again, you got to be kind of very scientific in sort of understanding what's coming before and after epinephrine and using other indices of perfusion in physical exam to determine your endpoint, not simply chase lab values that you might be creating with your therapy. Dopamine is an agent that used to be prominently used in critical care, kind of as a first line pressor, inotrope, general tonic, and then when it got to levels above 15 to 20, in some places, lower levels in our shop, usually about 5 to 8, we would start selecting agents from the inotrope and constrictor trees to then be a little bit more specific in treatment. It's still useful if you have a patient that just has kind of a sluggish blood pressure, kind of a sluggish heart rate, a little bit of myocardial depression, and they just think they need a little bit of a stirring up to get things going. Sometimes just low doses can just kind of rev up the circulatory system to that small degree that creates a little bit better global perfusion. Beta antagonists in some situations, and one I have kind of in mind is your post-op craniectomy patient. Say someone has an aneurysm clipped. Often those patients have incredibly high heart rates, and you're trying to bring their blood pressure down, their heart rate down, and it just does not work. That is because they're so centrally revved up that just peripheral antagonism just plain doesn't work. So sometimes you might put on an esmolol drip, and don't be shocked if sometimes in some patients that are just so stirred up centrally, just they don't work. And then finally, I think I discussed this earlier, calcium is a very important part of response to inotropes as well as constrictors. It's the calcium stores in the SR that are responsible for chronotropic and inotropic effects of the inotropes, as well as calcium stores from the SR being released, as well as transcellular fluxes in response to constrictors. So making sure that your ionized calcium levels are within normal limits is pretty important. Actually, it turns out to be that the iStat cartridges, those that are called the G8 cartridges, actually have ionized calcium on them, so you don't have to send a calcium sample to the lab and make albumin corrections. You can get that result pretty quickly in a couple minutes with an ion-specific electrode on your iStat. Okay, that's it for pressors. Thanks for paying attention.